Good afternoon, everybody. This is session 2 of Learning Community 4, Building Resilience, Navigating Crises Amidst Evolving Environments, De-escalation and Pathways to Recovery for behavioral health providers and organizations serving refugees and migrants. Wherever you are in your day, we're grateful that you're taking this time out to learn and grow and allow us, RMTAC, to support the amazing work you do. Thank you so much for joining us. My name is Mohammed Ali. I will be your host today. I am a clinical consultant at RMTAC, the Resource and Empowerment Technical Assistance Center for Behavioral Health. Today, we'll be diving into navigating change, building resilience for organizations, for ourselves, and those we serve. Our goal for this learning community is to foster a collaborative environment to share knowledge, resources, and best practices. Learning communities promote active collaboration and engagement. SAMHSA, our funder, emphasizes creating active learning and opportunities that help providers to integrate new practices that will impact the lives of those we serve. I encourage everyone to share your insights and ask questions throughout this session. My name is Mohammed Z. Ali. I am a clinically trained psychiatrist. I have over 10 years experience in academic and clinical medicine. I am a child psychiatrist also, and I have extensive experience with via Veterans Administrations as well too, as well as crisis management. As you can see from our agenda for the day, we have a robust session planned. We'll begin with introductions and learning outcomes. We will hear from our subject matter experts during the panel discussion, and then have an opportunity to ask questions and share your insights. I would also like to introduce our subject matter experts, whom you will hear from during our panel discussion. Amy Dominguez has 2 decades of experience and has implemented initiatives that create lasting positive change. In her current role, she oversees the Disaster Services Department at Vibrant Emotional Health. Gaurav Mishra, Dr. Gaurav Mishra, is a trained psychiatrist. He was the chief of behavioral health at San Ysidro Health in San Diego, California. In 2021, Dr. Mishra managed the behavioral healthcare team and mental health management of 3,500 unaccompanied minors until reunification. He is also the project director, principal investigator for SAMHSA certified community behavioral health grants, and is working on bringing comprehensive mental health and substance use disorder care to seriously mentally ill patients in South Bay and East County in San Diego. Dr. Mishra's experience is in research and evaluation, community mental health service delivery, substance use disorders, gender-based violence, human trafficking, psychopharmacology, child abuse, and crisis services. Also joining us today will be Mutsa Majero. She is a PhD in clinical and lead clinical consultant for the RMTAC team. She is also my supervisor and someone that I've gotten to know and respect as a clinician. She also has a lot of experience in clinical psychology and crisis management as well. Unfortunately, our other panelist, Alenga Alokalo, had a family emergency and was unable to meet us during today's session today. It is possible he may show up later, so if he does, we will definitely invite him in. Before we begin with our panel discussion, let's take a moment. We're going to review the reasons behind selecting this topic. We're going to summarize the key insights from session 1. We're also going to cover essential information and definitions to set the stage for today's discussion. So, with this modern era is characterized by an increased frequency and complexity of crises, ranging from global pandemics and economic downturns to technological disruptions and social unrest. These challenges often arise unexpectedly and can have profound impacts on individuals, organizations, and communities. In such an environment, the ability to not only withstand these shocks, but also to adapt and grow in their aftermath has become paramount. Building resilience at both personal and organizational levels is no longer a desirable trait, but a fundamental necessity for navigating the turbulent waters of our rapidly changing world. RMTAC was created to be a strength and support to you here in attendance. We provide consultation and technical assistance and have received significant interest in crises prevention and de-escalation for refugees and migrants. This interest is driving our learning community today. During rapidly changing times, Factors beyond our control are a source of frustration. Building on session 1, our group will explore this topic using 3 distinct perspectives and their connections. So let's talk about a crisis. Let's talk about crises, how they originate. What are some examples? That can be a sudden change, such as a policy shift, a natural disaster, or economic downturn, which creates immediate stress and uncertainty within the community. So let's talk about the responses. We have responses on 3 levels. We have the organizational level, we have the provider level, and we have the client response as well too. Organizational level responses are the way that leaders respond to the crises and can either create uncertainty or foster transparency, hope, and alignment with the organization's mission. Provider responses, the organizational response can then influence providers who may experience compassion fatigue, vicarious trauma, or burnout, and ultimately can lead to the client response, and how the provider response to each and all crises can then positively or negatively influence the capacity for the client to effectively respond. In session 1, we also addressed the prevention of crises. The main takeaways were that organizations should continue to utilize and nurture existing collaborations and to acknowledge crises and maintain transparent communication. Also, that providers should establish clear boundaries, provide regular debriefing sessions, promote self-care, and limit exposure to stressful media. And that clients should undergo early screening and identification, have support networks, and experience cultural competency. So, moving on to session 2, our focus will be on crisis de-escalation. When a crisis erupts, effective de-escalation techniques and strategic communications are essential for navigating intense moments. Crisis de-escalation involves using direct communication to stabilize and to reduce the intensity of the situation. The primary goal is to ensure the safety of oneself and others. Our objective is to learn from experts and engage in discussions with fellow health professionals. By sharing experiences and strategies, we aim to address crisis prevention in the context of our evolving environment. We aim to analyze crisis situations and effective ways to guide our teams through change and loss, and develop strategies for crisis prevention and resilience, including spotting early warning signs. So, as a refresher, here is the definition of crises we are using in this learning community. The American Psychological Association defines a crisis as a situation, example given a traumatic change, that produces significant cognitive or emotional stress in those that are involved in it. Additionally, a crisis can be characterized as a state of overwhelming that it inhibits one's ability to cope. For this learning community, we'll use these definitions to explore its experiences, the experiences of crises at organizational, provider, and refugee levels during times of change. To establish a common framework, we will first define the term crises and then explore its manifestations from distinct viewpoints of the organization, provider, and client. So an active crisis can look like multiple things. An active crisis can look like at an organizational level. It can look like operational disruption, reputational damage, financial strain, and legal and liability and legal concerns. Systemic failure. Operational disruption can include staffing shortages or rescue or resource depletion. Think of an example: a surge in emergency room visits, or a mental health facility experiencing a cluster of escalated clients. Reputational damage, which is negative media attention, lawsuits, or public outcry, can negatively impact an organization's reputation. Financial strain, along with legal and liability concerns, lawsuits, and security and facility repairs, or systemic failures. Crisis can reveal flaws in existing protocols, training, or resource allocation, forcing the organization to reevaluate its system. Essentially, the organization is looking at the bigger picture, focusing on minimizing damage and ensuring long-term stability. But what does crisis look like at the provider level? Well, the provider can experience emotional distress, ethical dilemmas, personal safety concerns, skill deficiencies, vicarious traumas, and decision fatigue, Emotional distress, performance anxiety, burnout, which are two very strong reactions to crises. Ethical dilemmas, balancing client safety and the autonomy, can create a complex ethical challenge. Personal safety concerns, risk of physical harm from agitated clients is a very real concern. I know personally myself, I've experienced that. Skill deficiencies, people feel unprepared for the crises that might be presenting itself. Vicarious trauma, constantly witnessing or dealing with traumatic situations can lead to vicarious trauma, which causes the mental health of the provider themselves. I've experienced that too. And decision fatigue. Making decisions like this constantly can put undue pressure onto the provider themselves. Also, then next the client. What does the crisis look like on the client level? The client can become emotionally overwhelmed. They experience intense feelings of fear, or anger, or confusion. They can experience a loss of control and a sense of isolation. They can experience trauma or be re-traumatized. They can experience physical distress and a fear of stigma as well too. So it's important to recognize these perspectives and that these perspectives are not mutually exclusive, that there are overlapping concerns. By understanding the various presentations of crises from organizational, provider, and client perspective, we can create a more effective and compassionate response. This multifaceted approach allows us to address the needs of all the parties involved, promoting safety, healing, and well-being. A key aspect of navigating crises is reestablishing therapeutic rapport post-crisis, which is crucial for preventing recurrence at all three levels after de-escalation. We will delve deeper into this during our panel discussion. Therapeutic rapport refers to the positive trusting relationship between an organization, its leadership, and its employees, as well as a therapist and a client. We will now turn our discussion over to our panelists. I will mediate the conversation and ask the questions. We will explore various perspectives on crisis prevention at the organizational, provider, and client levels. To our audience, we will post the panel questions to the chat. We will keep the chat open for you to share your insights and ask additional questions. At the end of the panel, we will have a Q&A session and a roundtable discussion. During the roundtable, we look forward to hearing your insights and any questions that you may have. Let's get started. To the panel, what types of crisis situations have you guys navigated in your role? Please maybe give me one example and how you navigated it.
So in our work in our
And
organization, we regularly are facing disasters as part of the work that we do in providing emotional well-being and support to organizations who are responding to disasters. Our most recent point of engagement was with the LA fires, and then the impact of organizations in Florida, some of the policy changes that were serving immigrant populations. So we are regularly faced with crises in that respect, and are active in supporting organizations and navigating how those crises and those disasters impact their own environment and workflow.
did you have anybody who was directly affected by the LA fires, who lost their home or anything like that?
So, I mean, yes, and personally, yes, but we also have organizations, partners that we've been working with who are facing um, really significant change in the rhythms of their organizations because they're displaced, like their actual location was no longer functioning, or in the case of one of our partners, they became the new home for schools on a short-term capacity. So their entire workflow and use of offices shifted in a moment's notice. Um, so yes, yes.
I can imagine how disorienting that would be and how disruptive that would be to organizations that are used to a certain protocol,
Yeah.
and that how this disruption is very just debilitating. Dr. Mishra, what about yourself?
Yeah, thank you. I think, yeah, definitely, condolences to anybody kind of who's lost during the LA fires. I think, I'm working with an organization where one of the staff also lost their home during that fire. It's definitely very traumatic for the region. Um, my experience as Dr. Ali, you mentioned, is primarily in the San Diego region post training. I've been working along the U.S.-Mexico border now for about 11 years. During 2021, this is a good example kind of representing the kinds of crises we face. 2021, we had about 3,500 unaccompanied minors housed in the San Diego Convention Center. And through my organization, I was kind of in charge of overseeing all of their mental health services. So obviously, this was in addition to all the work we were doing as a clinic, as a department within the organization, Monday to Friday. And if you think on the surface, addressing mental health needs for 3,500 kids is obviously, you have to do it differently. You cannot get one-on-one therapy in psychiatry for 3,500 people. And also it is not needed, right? So what we really identified was it's a little bit about resources and time, right? So the resources are materials and people, and also how much time is it actually going to be spent? What we did really is quickly went from clinician heavy model to our case management care coordinator team. We trained them, and within 3 to 4 days of trial and error, not in a bad way, but actually trying to do service with clinicians, but then realizing you don't need a therapist or a psychiatrist running a group there. We trained our case managers, and within a few days, we went from a few kids being seen to about 30 kids in a group, 4 groups a day. We were now reaching over 100 kids every day, 7 days a week. So with this kind of change of how do you approach this problem or task in a crisis, and there is a need, but assessing the need well, we were reaching more than 700-800 kids a week. So with those numbers, now you can get to 3,500 in a few weeks. It's a lot more achievable. And then we were also using our resources and people well, as in our case managers were running the groups really well. A lot of the need was around anxiety management and support amongst each other. But then kids, there were a lot of kids with more severe trauma, with psychosis, thoughts of suicide, kids with autism never been diagnosed. There are a lot of more kids who had a lot more complex need. Those we were triaging up to see our clinician, kind of developing a recommendation of more long-term plan that would be. So I really think one of the lessons, also we worked with over 20 different agencies from federal, state, county, city level, which is another challenge of its own, like kind of bring everybody together. But one important thing is really rethink what you're doing in that setting. The regular playbook does not always work in a crisis. So you have to rethink what is going to work and also reassess the need, not assume the need from the beginning, because nobody needed TF-CBT or trauma-focused CBT there. People needed support. And it actually would be wrong for us to try to do trauma therapy there unless somebody's symptoms were like on the surface and really impacting. So really not assuming that you know everything about how to run these things early on, assessing the need and just shifting how you're delivering care was critical, and it really made the project a success, and was well received by the kids and the other teams.
I just want to add what you just said, Dr. Mishra,
Right.
that exact point that a lot of times we come to these moments expecting or even assuming the need, but over time, that intervention that is anchored in the evidence-based work of like psychological first aid and frankly,
Right.
acknowledging the humanity of each other,
Yeah.
game changing in the way that
Right.
we think about system solutions and even just individualized care. So
Right.
props to that. Yes.
Thank you. Yeah, I mean, I'll just say one other thing is that what happened was the reverse. I actually learned things doing things there that I now do in our clinics in our regular buildings, like in our regular 4 walls, because now we use our care coordinators, case managers a lot more empowered. They do run groups for us. They have so much more impact today than they had before this crisis, because that crisis I didn't know everything about how to run that crisis, but that crisis actually helped me do things better on a day-to-day basis in our clinics.
Amazing. Love that.
Dr. Majero, can you give us an example of a crisis that you have you experienced and how you handled it?
Yes. So I have worked as a mental health therapist in a variety of different settings, all the way from working with children in residential treatment facilities, working in schools as like a school and community-based therapist, working in college counseling, private practice, all of that. And the situations that I can think of that are pretty relevant to to what we're discussing today are related to working with like international students in college counseling settings, or like students who identify as either refugees or migrants in college counseling. That was pretty challenging because you can imagine as students, there's just like so much pressure just being a college student in general, right? And then being a college student who is either a refugee or migrant, international
Oh,
student, there's
wow,
so
yeah.
much pressure of like back home for you to be an A+ student 24/7 and all of this. So when students were experiencing mental health crises in the college counseling setting, it was really difficult because there's so many other factors that come to play, like they're fearing, how is this going to impact my visa situation? How am I going to be deported? The fear of like being misunderstood, the stigma related to mental health counseling back home, fear of losing academic standing, fear of losing, scholarships, all of these like barriers are kind of in place that really put a lot of pressure on just, again, the culture of being a college student. And so in terms of navigating and helping them kind of through this, it was a lot of times, of course, it was just like immediate safety and emotional support. Like, what can we do immediately, right? But also that piece of like, the piece of trauma-informed care, cultural competency really came to play because kind of similar to what Dr. Mishra was saying, you can't just apply the typical type of like techniques that we talk about when it comes to crisis situations when you're dealing with individuals from different cultures. So, starting from basics, it was important to start from basics, clarifying things like confidentiality, helping, really using a lot of open-ended questions to help myself understand their view on mental health, so that I can kind of approach it and meet them where they're at versus trying to apply techniques and different things that, you're trying to apply things that from school, but when you're really like dealing with someone who doesn't understand how mental health works in a country, in a culture like this, or what are some of the consequences per se as to having like a crisis, it really was just going down to the basics and helping them connect with peer mentors, helping them connect with other students from their culture was also important. But those pieces of like immediate safety, explaining confidentiality, those were really like kind of just huge in terms of allowing them to feel like, okay, this is a safe space, and just focusing on immediate present steps and then like immediate next steps.
Wow. I mean, just with you bringing that back, like, just flashing back to my college days, I remember what it was like to be in college and have crises, but my family was only maybe 3 hours away from there. I could always call them up. I can't imagine what the people that you were working with their families being thousands of miles away, and them having the added complexity of the refugee migrant type of connect. That's amazing. That's fascinating. Really,
Yeah.
really. Dr. Mishra, I wanted to ask you something. Now, with your position as the head of the head of the organization and as a provider, you fit 2 out of the 3 levels of the kind of the crises, the response levels that we have.
Right.
Can you tell me, in your experience with when you were handling these situations as from an organizational and from provider level, did you see in your providers any of the factors that we have experienced today in terms of burnout, vicarious trauma, being feeling that they are not skilled enough to handle the situations that they've experienced? What other? I mean, can you tell me? Have you experienced other crises? Like
Right.
what? Can you give me like a broad overview of that kind of those 2 levels?
Right. Yeah. So, I think, I'll say that, in the moment, as I had to say yes or no, right? And I said yes. I was not necessarily thinking so far ahead for all the impact it would have on our team, but it just was an opportunity we had to say yes and try to help out with, right?
Yeah,
But
right.
at the same time, I think one of the things we definitely see is oftentimes in healthcare, we are adding work to our teams without
Yeah,
giving them more time, appropriate training, or reducing some of the other work they were already expected to do. This is so common in healthcare, unfortunately, that
right.
it's very easy to fall in that trap. I think,
Yes,
I think one of the ways to think about it is when, people, their time, their effort is all, um, are all, you need to, as a leader, you have to manage that and make sure you're not sending somebody down the path of a burnout, right? To some extent, what we did initially was really ask for, because it was going to be more work. It was not possible for us to kind of eliminate all of their tasks completely, maybe reduce it temporarily. But we really asked for people who would want to volunteer and do that work, because the expectation actually was you would need to work some extra hours on the weekends. That is not completely avoidable. We really had a few people who were very interested. We are very close to the border, so we are in a position. A lot of our staff are bicultural, bilingual, live on two sides of the border. So people felt this crisis very personally for a lot of them, and I think we were lucky enough to have people volunteer. But the other piece was we made sure everybody got paid for their extra hours of work, and it is not expected that you're just showing up to work. I think that is another piece that let's not assume, good intent and kind heart is important, but it's important to respect that people are putting their time and effort and pay them for it. So whoever was working full time got paid overtime, got paid the appropriate compensation for their hours spent outside of regular hours, outside on the weekend, for those 4 or 5 months that we were on this project. And really, other pieces, just checking in with the staff. A lot of these, sometimes we do the great work, and then the good output that comes out or the response that comes out doesn't get back to the team. The team doesn't hear about all the good outcomes that have happened. So we had a lot of positive response from not just the kids, but many other teams we had worked with. We trained a lot of other teams around how to manage some anxiety, how to recognize it. People had questions around, why would this kid have anxiety? I'm trying to help them, right? But the person helping them was not in healthcare, did not have that experience. So really trying to educate, that was very well received. So trying to get all of that positive input also back to the team was helpful. Yeah, those are some of the strategies we used. Yeah.
Amy, with the crises that affected your organizations, how did your leaders respond to the crises, and what was their response, and how did it affect the rest of the organization, and down to the client level?
Yeah, thank you for the question. I think what I'll actually say is what we have empowered leaders to do, recognizing that when you are leading in crisis, it is different than leading in what we would call blue sky days. So the strategies and the approaches have to meet the needs of the people in your organization. So when we provide training to organizations about leadership in times of disaster, we talk a lot about methods of communication that keep people in the loop, really, as to what is happening and the impact of what may be happening on their own individual workload, as well as their team's workload. So that can manifest in ways of regular daily stand-up meetings that might have 15 minutes to them, but have the same agenda every single time. The second is really being over communicative and visible as a leader. So, in a day and age where we are virtual, that is not as natural in the sense that we're not sharing the same offices a lot of times. But what does it look like to hold office hours, or to hold regular opportunities on Slack or other messaging apps to be available to your team for those check-ins and those temperature checks? The other piece that I think is really critical is that you are the one they are looking to as a model in how you take care of yourself. And so when you are clocking out for the day to be with your family, set the expectation for your team of what that looks like, and celebrate them when they align themselves with that particular focus of self-care. Crisis requires, there's all sorts of science behind this, but the way our bodies respond to crises require additional rest and restorative practice. And if we don't, as leaders, model that in the way, even if in the small ways, we can really miss an opportunity to keep our team engaged, strong, and resilient through that crisis. And the final thing I'll say is, more often than not, we forget as care providers that the same people who are providing care are often the ones impacted by that crisis as well. So we think about natural disasters of hurricanes and fires, but we also think of school shootings and human-caused crises. When we are community members, we are also facing the implications and the impact of those crises. So compassion, grace, and mercy. May those guide the way that you communicate and the way that you are intentional about setting expectations for your team and advocating for the needs of your team to the leadership that may be guiding the organization. So,
Dr. Majero, in your experience, what what strategies have you used to prevent burnout and vicarious trauma from yourself? Because I know that you've been involved with very intense therapeutic interventions. What have you used to improve your ability to respond to crises within an organization as a provider?
Yeah, that's a really good question. And you know, what Amy was talking about is like so key in terms of the like modeling what type of like emotional support you're implementing for yourself and what that looks like for team members, right? So in the spaces that I've worked, that wasn't always the case. The individuals that were doing most of like the hands-on work weren't necessarily receiving the type of support from leadership, you know? So it's like the leaders would leave for the day and we're still working and dealing with the crises, dealing with the children in residential facilities, all of that. So on my end, it was a lot of advocating for myself. It was really important. I think when I was a younger therapist, it was scary to want to advocate for myself. But I think as I kind of grew into my role, you really kind of understand that aspect more of like practicing what you preach. I can't be here telling my clients to take care of themselves, to advocate for themselves, to do all these things, and I'm not. And also when you think about this type of work, especially trauma work, you have to be present. You have to be present and you have to be able to support the clients that you're working with. If you're not okay, you're not going to be of any help to the individuals that you're working with. And it's very evident. Your clients can see it. The people that you work with can see when you're not okay. So a lot of advocating for myself, I think, was what was key to just be able to, like in specific roles that I was in, I advocated to be part of like committees and throughout our teams and stuff to be able to ask for things like, can we have mental health days? Can we have, meetings where we just kind of debrief and just kind of talk about what the week was like and all of that. So that was very important. And I think now that self-care piece, it entails a little bit of like selfishness in a sense. And
Yeah.
we see the word selfish as a negative thing sometimes, but it's important when it comes to making sure that you can show up, because when you show up as a therapist or a provider, the people that you're serving are expecting you to show up in front of them at 100%. They're not hoping to get 45% of you. So it's important to be able to be selfish in a sense, to make sure that you can restore yourself, replenish, get back to 100% so you can show up as close to that as possible. We can't always be at 100% all the time, but you can get close.
Absolutely. I mean, with regards to that, specifically at that point, if we're not at our best, if we don't have any, if we're not working well, what's the point exactly? Because they're looking to us for support. Now let's kind of delve a little bit more deeper into the idea of what exactly specifically have you done when you've been exposed to a crisis? What techniques have you used? Let me give you an example from my past. I know that when I was working in the VA, when I was doing the inpatient units, some of the veterans with mental illness would be very caustic and aggressive, and they would want what they wanted because they were not used to waiting, and so they would come to you as a psychiatrist and just start yelling at you and in order to get what they wanted. And Dr. Mishra, I'm sure you've experienced this too, where the patients will come up to you and just kind of give you a whole bunch of aggression, be very, very aggressive. But in terms of, you can do one of two things. Either you can back down, or you can maybe gently and respectively push back a little bit. So I can tell you, I'll tell you, more times than not, I've pushed back, not forcefully, but but respectfully and with some force, I have to admit. And most of the times I've always had the patients kind of respond to me appropriately, and ultimately we were able to come to a solution. This also works with children too. I'm a child psychiatrist, and so when children have tantrums, if you push back a little bit, obviously you're not being physical with them, but you push back a little bit and give them a little bit of advice. So most of the times they will back down, and they will accede to your demands, and they will play ball, if you will. So what have you guys experienced in your practice? I put this out there specifically to all three of you, and just pick one of you guys, and you just come back at me. What specific techniques and approaches have you used to de-escalate crises in your experiences?
I think, I think you mentioned, two pieces. I think the clinical piece for sure, I think setting limits and boundaries in a session is definitely critical. But I'll say that, in my role as a psychiatrist, I've also seen a lot of the negative interactions tend to happen more with front desk staff and to other staff who don't have that level of perceived power in the patient's eyes, right? So I think as a leader, one thing I've kind of emphasized here always is that everybody has the right to respect, and including all of our staff, and everybody has a right to feel safe in their workplace, right? So if at the same time recognizing a lot of our patients are going through many difficult situations in their life, and so we need to make accommodations for that. But at the same time, I do not feel if somebody's threatening or being very loud and intimidating my front desk staff, I don't feel it's okay for me to, yes, help out my patient, but continue to allow our front desk team to continue facing that or come to work with that concern, right? And I think not feel safe in a workplace. So I really think respect, I think within the team itself, from clinicians to non-clinicians, there's a lot of hierarchy in medicine. I think just setting that tone from the beginning, whoever it is expected to be respectful in their communication at workplace, I think is an important thing to consider.
Amy, anything, and can you give us an example of what you've experienced?
Yeah, I mean, I think again, we work with organizations that are responding to disasters, and so a lot of times they're facing challenges from pressure from board members who have different expectations. They're facing their own personal suffering. But the way that we tend to help support is just providing space for intentional processing of what is going on and providing guidance around preparedness. So I think the best thing an organization can do, because crisis is a when, not an if. Like the reality is that, the frequency of events continue to increase. And so the best thing an organization could do is have what we would call a disaster preparedness plan. So really a strategy of how to navigate something when it happens, and who are the points of contact, what are the resources available, and having that clearly laid out. And there's some really great models out there that are not overly complicated. And then getting that buy-in at all levels of the organization really sets up that organization for success in the midst of intensity. And that's something, unfortunately, we get requests for in the midst of responses. Like, we should have been prepared, help us be prepared. But we really do advise that in these times where there may not be something actively happening, to take that time and plan. So that would be something I'd put forward.
Okay, thank you very much, Amy. Appreciate that. Dr. Majero, do you have any specific techniques or anything that you used to de-escalate crises?
Yeah, I think a lot of great points have been shared already, but I know in my experience in terms of more one-on-one crisis situations, I've found that a lot of times people just really want to be heard and really want to be seen, right? So really allowing kind of like space for people to express what they're experiencing, and not matching if it's like heated, not matching that tone. I think it's important to firmly establish boundaries, especially like way beforehand with clients and patients in different settings. It's so important to kind of set those expectations really early, where it's like, in times of crisis, this is what our crisis plan looks like. This is kind of like how we address crises, you know, kind of talking about like not tolerating disrespect towards like front desk staff as discussed earlier, all of that. But then in the moment, in the heat of an actual crisis is just to kind of, I think it helps to not match the heated level of how your client may be, but to really just kind of reestablish those boundaries, kind of like basically remind the client of boundaries that were discussed earlier. And then again, in the moment, provide just space and opportunity for the individual to express whatever's going on. And then using just like clear, calm, honest, you know, communication to just really focus on the present, focus on immediate next steps, and just kind of keep it in that space. Because a lot of times when individuals are in crisis, it's compounded, right? It's like, oh my gosh, what's going to happen next week? What's going to happen the week after? What's then, you know, so it's just, it helps to just be kind of focusing on immediate current safety and immediate next steps.
So I'm gonna kind of ask a question of all three of you guys, and also we're gonna put a slide out to the audience as well too. What are the main challenges that you guys have experienced in terms of attempting to de-escalate a client?
I think challenges are of sometimes the systems that work to serve patients in crises are not really working very well together, right? So I think you could determine this patient, you know, I know San Diego County that we're in, it's the care is a lot of it, the care is fragmented, you know, and so I think when you think, oh, this patient is in crisis, we need to connect them to a 24/7 mobile crisis unit. Yes, you do that, but you don't always get the phone call from the mobile crisis unit to know what happened to your patient, right? Or do they then get connected appropriately to a higher level of care if that's of need? So those gaps in care, yes, we want to resolve this immediate crisis for a patient, but planning the next many steps for this patient is a challenge, and oftentimes you're dealing with the same challenge for each patient individually, trying to navigate where that it's difficult to face one challenge and have a plan that works for all patients. So I would say that's one of the biggest challenges around dealing or working with patients who are in a crisis. And many of our patients have many crises. They may have a mental health crisis, but they also may be unhoused. They may not have a source of income. They may have other domestic violence or substance use related issues. So those are many different complex things happening in a patient's life that get them to this point where, you know, one thing is not going to be sufficient. But again, I do also say it's important to remember, like, each effort matters. It does make a difference, even if you get them from a 1 to a 2 and not 1 to a 10, which I know all early stage clinicians really aspire to get them to this final everything works out ending, but for many patients that's not possible. So if you move them along, I think that's still success.
We have some responses to the Slido. This one here, the first one is pretty interesting because I know I've experienced it myself. The response was staying calm myself as I de-escalate an elevated client. My somatic responses are difficult to control when I'm focusing on being present in the moment and put my training in practice. I know that as clinicians, all of us have experienced that. I know that I personally have experienced that too. You have to really learn to rein yourself in to treat the patient with respect and autonomy as well too. And so I can completely empathize with that. What about you guys? I mean, tell me, do you guys have similar histories or experiences? And how did you guys deal with those?
So I want to offer a resource. I've been working, I am not a clinician, but I've been working with psychiatrists for almost 20 years in disaster response. So I've learned a lot about how certain approaches can really help in those heated and really aggressive moments. And so psychological first aid, which I know I'm hopeful that many of you are familiar with, serves as a really helpful guide in de-escalation, and has 8 components that really focus on helping a person, first emotionally regulate, understand a sense of safety, understand the resources available to them. But it's a regular thing that a good colleague and friend of mine, Dr. Sander Koifman, regularly said, the first approach is the most important one. So the way that you interact with a person who is de-escalated, that first interaction, even your physical posture, can change the trajectory of that person's experience. So again, want to point to psychological first aid as a baseline to, encourage you to see the person before applying your diagnostic therapy work. So
Thank you for that, Amy. We have an interesting question from the chat. I'm going to post this to the panelists. The question is, could the panelists share best practices for engaging with traditional Afghan families where cultural religious norms may limit family members' participations or cause for no participation at all? Even in the United States, specifically, how can we ensure women and girls receive services while respecting family boundaries? A really great question. Thank you so much for that.
Our organization was really active in Operation Allies Welcome, which was the national initiative in welcoming our Afghan guests and helping them get resettled here in the U.S. A few years ago. And this question came up a lot in terms of the mental health practices on the bases across the country. And a lot of our clinicians found strategies that allowed for women to receive services in a different way. So it looked a lot like group settings. It definitely looked like female to female support. And if there was a male clinician, really respecting the male presence in that space. And I think one of the things that we often encourage with cultural competency was letting them teach you what that interaction should look like, not being afraid to ask the question. Here I am, a white woman providing support. I am not Afghan. I don't know your story. Help me understand what best works here. And I think another piece is language, ensuring that you don't just have someone who is fluent in whatever dialect that they're speaking, but who has specific training in providing interpretation in health and mental health dynamics. Because a lot of times people that speak the language but don't have that training will summarize what people are saying and often miss important nuances that as a clinician would be very helpful to you in providing those next steps for wellness.
Did you notice any resistance in terms of implementing the mental health solutions that you guys were suggesting?
So, I think that whenever anything is unknown, you do experience resistance. But I will say, at least in those spaces, the immediate question was, where are we going? And what is next for us, and how do we take care of our families? So the pressing needs being addressed was a part of that case care. And as people began to understand the roles of each person on their involved on their team, their care team, that resistance shifted from being open to inviting and having a tea ritual and just approaching it in a different way. So I think a lot of people, at least in that particular scenario, had pretty stark questions of what was next for them, which allowed for conversation to occur, actually.
What about support networks? Did you notice were there extensive support networks for those particular people? Anybody? What about support networks for your particular patients? Have you noticed support networks improving the response to the client's emotional needs?
Yeah, Amy brings up a lot of really great points. And in terms of support networks, I think this is where bringing in individuals who are obviously very familiar with the culture to serve as the term cultural brokers is helpful, because a lot of times they can help you frame how the support that you're providing is going to be culturally relevant, right? So it's like, this question is saying, how female members' participation or excuse me, it says how women and girls receive services while respecting family boundaries. So enlisting the services of cultural brokers can assist with helping to frame how the support that your organization would provide, how does that tie into their role as women in their family and their culture, or if religion is a big part of it, how can the cultural brokers also kind of help the family members almost buy into the services, right, that you're providing. Frame it in a way where it's relevant to their culture, and they see the value of how this can enhance, the women's roles within their families. So that can maybe at least get them there, and then you're able to provide, like those spaces where, like, gender affirming spaces where women are able to receive support from other women and all of that. But that piece of like buy-in, I think it helps to have those who are familiar with the culture to assist with that.
Dr. Mishra, did you have any kind of exposure to support networks amongst the charges under your leadership?
Yeah, so we had, I think the support networks were, in that moment, the support networks we were working with were not necessarily their family members, though they were there, but it was very unclear early on, like, who is some kid going to get reunified with, who they're actually going to go live with. And that was almost decided last moment for a lot of the kids, even though that work was ongoing by the social work team. I think, oftentimes we'll be in a situation that I think, as both Dr. Mutsa and Dr. Dominguez have described, it is really important to see what the immediate need is, right? So if somebody does not know where they're going to be, so I think that level of anxiety around uncertainty that they're dealing with at the moment is really the critical need of that moment. And it is important to address that first, and because resolving some of that, or at least helping them cope with uncertainty or learn how to have some strategies to cope with uncertainty is actually going to go a long way in that moment. And I think one of the ways we see for people who are not very engaged in the community, for sure, that makes a huge impact. Having somebody who knows the culture, who speaks the language, who is able to interpret well, makes a huge difference, because I think even explaining it culturally appropriately is different. And I think, like, the term I learned very recently is cultural humility, which is, I think, it takes away from cultural competence, which is that, yes, we are trying to be culturally competent, but, I think just being humble about it, being curious about it, going from a place of wanting to learn, I think goes a long way. For women, of course, I mean, a lot of times they'll not go for their own care, but they will take a child, they will take a family member for care. We see that across cultures, and I think one way to get women into care is making sure you're providing pediatric care or child care, things like that. I think those are some strategies to consider. A lot of the postpartum depression is detected in pediatrics clinics, not in OB clinics, right? Because they will not miss the pediatrics follow-up, but may miss the OB follow-up. So I think some of those strategies also help, knowing what they are in need of and helping them with that.
Those are fascinating points. I appreciate that. Thank you so much for that. So we're going to put a poll to the audience. On a scale of 1 to 5, how well do you think your organization ensures the safety for all involved during a crisis? So go ahead and put that in the chat then. Go ahead and answer the poll there. And to the audience, to our panelists, how do we ensure safety for organizations, providers, and clients during an active crisis?
So I think, again, it comes back to the different levels of safety, right? So, obviously there's
Right.
safety and mental and emotional safety are equally as important in all of this. And it comes down to planning and value-based planning. So really anchoring in that organizational values, your mission, your vision, and really scrutinizing what does it look like for us and within our own context to establish rhythms of safety for our team. It's hard conversations. It requires input from the team as well, which can be tricky, I think, at times. But when it is a collaborative process, it really does render stronger results.
Absolutely. Dr. Mishra, with your large organization that you experienced, how did you guys ensure that all three of your levels, all three of the proper levels were provided for in terms of protection?
So I was kind of in the middle, and I think one of the important pieces was kind of making sure the communication and needs are clearly expressed to both, right? So the frontline people who are in the work, do they have the resources? Do they have the time to do the work? Do they have the training to do the work? and what else is needed as far as personnel or other things that they feel confident and safe to do the work, right? And making sure the executive team and the people who control the money and the resources hear that completely, right, and fully. At the same time, many organizations will make decisions at a very high level and not often pass down the communication and reasoning behind decision making. I think that making sure that pathway really is functioning well and people know why something is happening. I think our employees are adults. Sometimes organizations will treat them like children, which is not good. And to make sure you trust them and communicate effectively, consistently, repeatedly, and not hide information, because if things are not working well, everybody can see it. The fact that we're not talking about it only says that we don't want to talk about it. I think so. I think that's how we try to do it, and it did work. It doesn't always work, but in that project, it did work.
How did your organizations and reestablish therapeutic rapport with your clients after crises?
I think it comes back to what I've said, I think, a couple times, like being human first when you're interacting with your team. Not forgetting that the person that's in front of you comes with a story, has a name, has a journey that is valuable, worthy of respect. I think it also means following that old adage, be quick to listen and slow to speak. And in crisis, we have a temptation to move very fast, and there are moments where that is necessary to make decisions clearly, quickly, for the sake of everyone's safety. But especially when you're working on that one-to-one level, seeing that individual and mentally, like, taking the pause before you begin the interaction to remind yourself of these things. For me, sometimes it's actually taking 5 seconds before I enter the room, whether it be virtual or physical, to reset my body and to be aware where I'm holding stress or where I might have trigger moments based on my own emotional capacity. So a lot of this can help move into a place of trust with that individual or with those people, and to demonstrate that you're willing to see them for who they are and not just the role that they play related to you.
Yeah, crises are uncomfortable, right? So I know a lot of times post-crisis, people just want to kind of like move on.
Move on.
But I think it's so important for, leadership to really like name the crisis, like acknowledge it, like put it out there, be open, provide like spaces for staff to safe spaces, not just anything, safe spaces for staff to actually like debrief, talk things through. Transparency is key. So really not over promising, because I think a lot of times, again, in uncomfortable situations, you just kind of want to get past it. And sometimes leadership may over promise specific things. So I think it's just important to be honest, provide spaces for staff to be able for you to listen to staff concerns, and then also just allow for conversations to happen and ensure that like their psychological and emotional well-being is prioritized. Like, what are active steps that are being taken to make sure that your staff is going to be okay? And maybe even create like committees using your staff, like enlist your staff to be a part of some of those processes, because again, a lot of times those who are doing the hands-on work were directly impacted by the crisis. They're not always like heard up in those like leadership spaces. So making sure that whatever the next steps look like, really you're involving those who have been impacted to help determine what those next steps will be.
We have our Slido back, and it looks like the majority of the respondents selected a 4, meaning that they were mostly effective in terms of dealing with crises, and the organizations were able to handle situations. I myself have experienced that as well. When I was at University of Iowa, we had definitely several crises during my time there. We had several psychiatric crises that caused a lot of problems. And the organization was able to really kind of bounce back and to support the providers and also ultimately provide support to the patients. So, I mean, it's a real blessing for people like us to work for organizations that can actually handle situations. So I think that that when you work for an organization that can handle a crisis, I think that's really a fortunate situation, because we all know that there are organizations out there that can handle difficult situations and that fall apart. And I think it's an important facet to, when you're thinking about going to a new organization, to see how they handle crises in terms of the movement, in terms of how they respond to it. So we're coming down to the end of the panel discussions. I want to say thank you for your discussions, but now we're going to open it up to the question and answer portion. So now we're going to open up to the audience. You can either put your questions in the chat, or you can unmute yourselves and you can just throw your questions out there. We can have a roundtable discussion for the next few minutes. If you had a question that you weren't able to ask during the previously, please bring it up. Where the mics are open, the chat is open, and so we'd love to hear your questions. We have a question in the chat that says, "How can we reestablish rapport with a client after a crisis?" I think we kind of went through that just a few minutes ago. But I had a question for you guys, actually. As experts in this field of crisis management and de-escalation and organizational responses, how do we de-escalate a crisis that the system itself has created? And when do we not have a solution? And first of all, let's answer the first question. How do we de-escalate a crisis that the system creates? Throwing it out there to you guys.
I mean, those are, by the way, unfortunately or fortunately, those are my favorite kind of crises, because fixing the system is something I enjoy doing. But I think, a lot of the problems are system related, right? I think the problems the system creates are, how do you resolve that issue? Is really first by acknowledging it and communicating to whoever the highest level authority person is or decision maker is. But oftentimes system change cannot be driven by one person or one department. That is a system. So you need partners from many different, if my electronic health record is not working well and it's causing a lot of problems, I cannot just tell my CEO to change it. I need to make sure the IT team agrees with my ideas and understands what the technical issues are, and so do all the other departments who use our EHR, right? So for that, I think for that kind of system change, you need to really identify all the different stakeholders. They may not always be the top people in their departments, but they should be people who recognize, maybe align with you, and are willing to speak up, right? That's how a lot of that system level change will happen, by building that coalition of people who may be kind of at your level or around that level in different departments, and kind of saying the same thing repeatedly in different rooms. That makes a difference. I think system change takes time, but it is doable as long as you have the buy-in, and that's the piece that it's important to work on. Yeah,
I agree completely. So then, what are some of the best practices for clients refusing mental health referrals after a crisis? Put it out to the audience as well. Maybe you guys can put in your suggestions as well. How can we help clients to see that it's in their best interest to be referred to a mental health provider? And naturally, I mean, there's a lot of people that have the pushback, and they don't necessarily see the benefit of it. What can we utilize to get the buy-in, like you said, Dr. Mishra, to get the buy-in that they'll benefit them, that it's a benefit to them to go and see a mental health provider?
So I have an opinion, and I don't know if it will be shared, but I'll say it based on what we've seen in the research over the past 2 decades of disasters and crises, is that people do not often have the capacity to understand how they are doing emotionally or mentally until about 3 to 4 months after an event occurs. And that really has to do with the old Maslow's hierarchy of needs issue, where, if you think about, we mentioned the LA fires, people who have lost homes, who have lost family members, who are completely upended in their lives. The last thing they want to be doing is sitting down in a counseling room getting mental and emotional support. But we do find that at that 3-month mark, 90 days to 120 days after the event, is when some of that proverbial and real dust has settled. They may have found temporary housing, and it's time to check in with the rest of themselves. So I think when we're working with people who have been displaced from war and trauma, we also have to acknowledge that when it comes to are their basic needs met, so that those conversations about being the most resilient, strong, at full capacity person they can be addressed. It is really difficult, again, as the non-clinician, but as the one who's watched a lot of clinicians do this disaster intervention work. It really is about stabilizing for about 3 months, and not about treating. And it's actually the people that have already diagnosed mental health issues, or have needs or on medication in the middle of those individuals already have that support in place. So it's really the folks that develop responses to these events that need support. But we do also see those symptoms decrease quite significantly over the course of time as well.
Thank you. I appreciate that. There's actually a question in the chat, and I wanted to ask Dr. Majero. Dr. Majero, for refugees and migrants, once they have had a negative experience with a provider or with the system, is it hard to reestablish trust? How can we do this?
That is a really good question.
Yeah, it is.
It is hard to reestablish
Yeah.
trust, right? I think patience is key. Patience and consistency in this space is key, because if someone has had a negative experience with the provider, of course, they may have already, like if we're talking refugee and migrant clients, they may have already had some mistrust with the system in general, all of that. So that kind of like almost affirms that this isn't a safe thing for me to do, to seek help, right? So I think it's important to acknowledge, whatever hurt may have happened with the previous provider, and just, I think it's going to require a lot of patience on the new provider's part, and again, consistency. Provide a safe space for them to talk about maybe what previously happened. Provide a safe space for them to discuss what they hope to get from you as a provider. And then just kind of work your way through that space of like, how can you show up for the client in the way that they best need. Kind of similar to what Amy was saying, like a lot of times we may think like, let's get you into mental health services first. We're thinking we may know what's best for a client, right? But it's important to hear it from them. What are the most immediate needs for them? And then you can get to a place where once you've shown up, you've provided support, you've been a listening ear, all of this, then you can get to the conversation of, all of these things that you want to achieve, accomplish, all of this could really, like having mental health support could really get you to that place. And really just kind of breaking down what that might look like. But it does require a lot of patience. The consistency on the provider part is also important.
Absolutely. And interestingly enough, there's a comment in the chat along those lines. This is from Lubna. It says, in my experience, it is beneficial to communicate with your client with transparency and actually listen to their perspective. Sometimes, in fact, often, it is a matter of being heard and respected. Remember that they are adults in their own situations. I completely agree with that. Dr. Majero, I'm sure you do as well. Can you elaborate on that a little bit? We've spoken that a little bit. Can you go at length? Can you elaborate a little bit more about that?
I think that's a great point in terms of like the last statement. Remember that they're adults in their own situations, because a lot of times these individuals who've been displaced, a lot of their like sense of agency has been taken from them, right? They feel very much out of control. Things have happened. They've landed in situations they never thought they may have been in. And providing a place where they not only have options, but also just have something that resembles empowerment, giving them back a sense of control, not dictating what's going to be best for them, but allowing them to kind of come to those conclusions, provide all the options, and allow them to be able to pick what they feel is going to be best for them, along with, of course, your guidance. But really, that sense of agency is going to be key.
Okay, I agree completely. So that's an interesting set of points that we have been discussing. I was just wondering, so what are some practical de-escalation techniques that we can use with children? Have you guys had any experience? I mean, Dr. Mishra, I know has had experience with children as a child psychiatrist, I as well, and I'm sure Dr. Majero has had too. So what have you guys noticed that are specific techniques that you've actually worked with that actually have worked with children?
I mean, so for one thing kind of that's different than maybe adults working with children is that children respond to I mean, adults do too, but children really respond to the environment they're in. So it's not uncommon for you to see completely polar opposite behaviors at home and in school. That's not an uncommon thing for us to see clinically, right? So that tells you that this kid can hold it all together, everything is working fine, functioning well, grades are good, everything in school, but at home, so I would really start looking at what's happening, where is it happening, and who is the support system, right, for this child. I've worked a lot in the foster system and kids, with unaccompanied minors, of course. I know, fortunately, kids, it's people don't like saying this, kids are resilient. They do get better. They need one adult in their life who's in their corner, and that makes a huge difference, even having that one adult. And unfortunately, there are kids who don't even have that one adult in their lives. But having that one adult makes a difference. Really empowering their support system is a lot of the work also. Especially for younger kids, empowering, sometimes I've seen a kid speaks only English, grandma speaks only Spanish, they live in the same household, and generational gap, of course, how each was raised very different. So there's a lot of gap there that can be that the caregiver, the primary caregiver, if they receive the right support, goes a long way. So I really think a lot of, especially for the younger kids, a lot of the work is around that. And then for the older one, they may be in an environment that's not the best, but maybe a teacher or somebody at school is somebody who they can rely on, or a sibling who could be their support person. So really helping them trust and build that support system kind of goes a long way. Yeah.
Yeah, support systems and adults that they can trust are so important to children to kind of get that kind of appreciation for it to go along with the treatment and therapy. I mean, otherwise you have a defiant child that will not listen to anybody, and you're just back to square one. I would like to thank our panelists for joining us and sharing their time and expertise. I really would. Now, what I think we should do is we should go on to the summarization. Thank you so much to all our panelists. Appreciate it. And now we're going to go to our summarization about what we accomplished today in session 2. So what we're going to do is we're going to talk about the summarization of session 2. The crisis de-escalation considers the top-down approach to crises, ensuring organizations and providers and clients' needs are met. Therapeutic rapport refers to the positive, trusting relationship between a therapist and their client. It's built on mutual respect, understanding, and effective communication. This rapport is crucial for successful therapy as it helps clients feel comfortable, understood, and supported, which can enhance their willingness to engage in the therapeutic process and make progress towards their goals. Supportive and collaborative environments support and collaboration amongst organizations, providers, and clients during times of crises can minimize the uncertainty of change. So, now to close out this learning community, I will share a survey link to complete. Through your feedback, we can ensure that we are truly meeting your needs. We will also send a handout summary with other learning materials from this event. Just for your information, Learning Community 5 is June 12th and June 26th. Please provide your email in the chat so that we can invite you to attend. At RMTAC, our services are completely SAMHSA funded at no cost to you. If we do not get to your questions, or if your organization would like to ask have additional assistance with any other topics related to serving refugees and migrant communities, our team at RMTAC is here to help you. You can submit a consultation and technical assistance request, and we will respond within 1 to 3 business days. This slide shows how quick and easy it is to submit a request. Simply visit our website, click on the Request a Consultation and Technical Assistance button at the top right corner, and complete this form. We also encourage you to visit our website at rmtec.org, where we have additional educational resources, such as our first learning module and recordings of our first learning community, and in addition to extensive resource directory. Before you log off, please take a few minutes to scan the QR code or to use the link dropped in the chat to complete our survey and provide feedback on this learning community. We are SAMHSA funded, and the feedback helps to continue the work that we do. I would like to close this learning community by thanking all of our participants for your engagement throughout. Thank you to all of our SMEs for their insights and expertise in this topic. Thank you to the RMTAC team. Otherwise, I'd just like to wish you a good afternoon, and thank you very much for your participation. Thank you very much, everybody.
Thank
And
you.
we'll look forward to seeing you in the next learning communities.